Welcome to the third episode of this case discussion series. I'm Phil Weinberger, and 3 words: bloody tooth guy. That's right, we've got Jason Auerbach. So Dr. Auerbach's a board certified oral maxillofacial surgeon, also known as Bloody Tooth Guy on Instagram. He's got tons of followers, excellent content, so definitely check him out over there. First, he's going to talk a little bit about what he and his partners, Dr. Sung Cho and Dr. Sean Lin, are doing at Riverside Oral Surgery. So they're actually up to 10 Riverside Oral Surgery locations and 3 locations still being operated under the oral surgery group. So after learning a little bit about the practice, we're going to go through 4 separate cases. Throughout all of their locations, they're using the CS8200 3Ds and the CS9600s for the most part. So I thought it would be good to have him go through a few of these cases, kind of what his approach is when planning implants, whether it's a simple case or more complex, just to kind of run through how he's approaching the case, how he's using the Carestream software, and just kind of talk his way through it. Nothing super fancy, just a nice walkthrough for all experience levels, and I hope you enjoy it. We're live. Jason Auerbach, what's going on, man? Thanks for doing this.
My pleasure. Thanks for having me, Phil.
I appreciate it. Before we even get started, I had to make a comment. Like, you sold your soul to the devil, right? Like, I'm not even talking about Riverside. I'm not talking about Bloody Tooth Guy. You know what I'm talking about?
Are you talking about the devil?
Look at that head of hair of yours.
What it is, it's basically the only thing I got left going for me.
It's amazing. Amazing. All right. Anyway,
I appreciate that.
So anyway, thanks for doing this. I appreciate it. We'll get into the topic here in a minute, but before we even get into that, just want to make sure kind of the audience knows a little bit about Riverside. So I wanted to tell everybody a little bit about what you guys are doing over there at Riverside Oral Surgery. Your growth has obviously been huge over the last several years, and you're doing something a little bit different. How are you different than a DSO? Why don't you talk just a little bit about that?
I've been in practice since 2003. I practice in New Jersey. I am the founder and president of Riverside Oral Surgery, which I started back in 2007. We are the official oral surgeons of the New Jersey Devils. So I started Riverside Oral Surgery in 2007 in Bergen County, New Jersey. Quickly grew to 3 locations in Bergen County, and then thought that maybe we could take our brand of oral maxillofacial surgery to a location somewhat distant from where we were practicing, where we enjoyed a pretty good reputation. So we opened our first office in Essex County a handful of years ago, and since then have really partnered with a number of practices throughout the state. We had 10 locations, 14 surgeons, and over 100 people working for us before we took on some investors in September of last year, 2022. There's been a lot of consolidation and interest by private equity and DSOs in specialty dentistry, general dental DSOs, large national multi-specialty groups, and also large national, specifically oral surgery platforms. And after kind of looking at all the options, it was clear to me that we didn't really want to partner with a large national DSO that was general dentistry based. Just didn't fit our model. We also didn't want to just kind of be a cog in a wheel of an existing platform. We thought we had more to offer in terms of the way we differentiate ourselves. We provide full scope oral maxillofacial surgery. We have 4 fellowship trained surgeons, everything from cleft and craniofacial to head and neck microvascular surgery, cosmetics, and TMJ. And of course, we do full scope dental alveolar, trauma, pathology, all that kind of stuff that all oral maxillofacial surgeons, or most oral maxillofacial surgeons, treat. So what we did was we set out to find investors who would support this concept of having an autonomous, independent clinical advisory board that would really run the delivery of care while they focused on supporting and managing the business, because that has become significantly more complex as you scale,
like
as you get bigger.
keep the clinical, keep the corporate, and kind of really separate
That's
the two,
right.
right?
Exactly,
Yeah,
totally
that's
like
good.
a separation of church and
Yeah,
state concept. So we set out to start our own platform, which we did form in September. Most recently partnered with a group that is equally distinguished in the state, maybe not as large footprint, but they have a 75-year history down in Middlesex, East Brunswick, and South Brunswick, called Oral Surgery Group. Exceptional bunch of surgeons, 6 doctors, 3 locations, and a tremendous reputation down there. So our goal is to build a platform of like-minded surgeons who are focused on quality of care, who want to really preserve and define what oral maxillofacial surgery is going into the future, understanding
yeah,
that consolidation in our industry is inevitable, as it has been seen in all facets of healthcare. And so for me and for us, this is a really important differentiating factor.
yeah.
So that's what we're trying to do. That's what we are doing.
That's great. No, it's been fun to watch. We worked together since the one office, so it really has been a fast growth to this size. So it's been fun to watch, been fun to kind of be along for the ride. So that's all good. Appreciate that. And I think the topic that you and I talked about today is just really kind of get into it right now. We're basically just kind of getting your thought process on just going through like a few different types of cases, maybe a simple case, a little more complex case, and maybe something even a little bit more complex than that. Likely there's going to be different types of audience members watching and different levels of experience with placing implants. And I thought it'd be a good approach just to kind of see what you're doing, how are you doing it with the software, what you're visualizing, even what your communication process is with referring dentists and things like that, just to kind of walk through that whole process. So we can get into it. And I guess you can, if you want to share your screen and kind of get into the first case, we can kind of go from there.
Sure, let's do that. Okay, so this patient was referred to me by her general dentist for evaluation of some discomfort that she was having on the lower right-hand side. Unfortunately, the discomfort that she was having was on the interior of her jaw, medial to the inferior border of her mandible. That means closer to the midline of her neck. And there was really not much that was visible to the general dentist on periapical film. So what we did was we brought the patient in, we had a cone beam CT taken, and this was the result. So just to kind of walk you through how I go about looking at things, basically, I start with the axial view on curved slicing, and what I do is I will trace the arch. You can see in this area here that there's an area of lucency that breaks through the lingual cortex of bone. So we basically trace the arch from the right side all around. I try to use the root canals to actually, the nerve canals to actually trace the arch. So now you have the panoramic view, which everyone is kind of consistently looking at in their practices. And you see here, this is kind of subtle. I mean, you see there's a root canal. Maybe this is a hint of something, but you don't really know exactly what's going on. So the beauty of the CBCT for me, and the way that I look at these CBCTs, is if you remember on the axial cut, you can see that there's a perforation in the lingual cortex. You take this blue line, which creates a plane of information, and you actually look to find that lucency, and now you're there. And then you go to the cross-sectional bit of information. So again, just to understand a little bit better, you have your parallel, your line here that I parallel more or less to the long axis of the tooth I'm looking at, and that creates a cross-sectional bit of information. So the cheek is out here. This is the sinus, the roof of the mouth, the tongue would be sitting in here. And here you see the tooth with this periapical radiolucency or periapical pathology that perforates into the through the lingual cortex into the floor of the mouth, which could yield a submandibular space infection. In this case, it was caught early enough that we did not have a concerning fascial space abscess. But as you can imagine, if you're taking a 2-dimensional X-ray with a periapical film, you're basically having to shoot an X-ray through here, through this dense cortical bone, all of this bone within the actual cortices, and you don't really appreciate the significance of what you're dealing with here. This is really helpful and is really demonstrative of why cone beam CT should really, in my opinion, be standard of care for dental imaging. But again, you're looking at a two-dimensional X-ray here, which does not tell the story, whereas this tells the full story. So of course, you know, as an oral surgeon, this is a pretty standard thing for us. The tooth was extracted. All of this was cleaned out. We are concerned about the proximity of this periapical radiolucency to the nerve, but we were very careful. We placed a amniotic chorionic membrane over that nerve to kind of wrap the nerve, and then we grafted bone around it. So patient returned.
Do you know what was causing the defect, or what caused it?
It was a recurrent infection from an old root canal.
Okay.
So immediately post-operatively, after the extraction and bone graft is performed, I use allograft, which is a particulate cadaveric or human bone that is cancellous in nature, small particle size. I reconstitute it with sterile saline. We make sure we aggressively clean out the socket so that we have really good condensation of this bone. And then we place an amniotic chorionic membrane on top, a figure-8 chromic gut suture, and send the patient on their way. Immediately post-op, this is what the X-ray should look like. We obviously I actually don't typically take a CBCT at this stage.
Got it.
Then patient returns after a 2.5-month lag. And at that point, we do another CBCT to see if, in fact, the patient is ready for his or her, in this case, her implant. We place the blue line or the plane of information to create the cross-sectional image of, to me, where I perceive the implant should go at the long axis of the adjacent tooth, parallel to the long axis of the adjacent tooth, again, kind of mid-implant. Then I go to the cross-sectional bit of information. This, as we know, is the mandibular canal. In it is the inferior alveolar nerve. We want to stay away from that. Initially, we'll generally just measure. Here we have 8.6 millimeters from where I perceive I would get a flat surface. So basically now you see, if I were to measure from the top of the bone, it's 10.7, but you understand that an implant has a certain diameter. In a lower molar, I want to use at least a 4.1 millimeter implant, ideally even wider, so 4.8 millimeters in my hands and with the system that I use. So basically what I'll do is I'll actually get to the point where I think I can do that. If I go to 10, I'll be right on top of the nerve. We all know that you want to stay about 2 millimeters north of the nerve. That's textbook. So let's go 4.8 by 8. Let's remove the measurement. Let's move the implant to where, let's move the implant to where it's fully immersed in bone. And as you see, should hit the central fossa or the palatal cusp of the adjacent or the opposing tooth, sitting all in bone, sitting well away from the nerve, sitting well away from the cortical bone floor of mouth. I'm comfortable with this. I then go back to my panoramic X-ray. I kind of get a sense of, again, the angulation, what it's going to hit on the opposing arch. Is it more or less parallel to the long axis of the adjacent tooth? And I'm confident that this is good. I then schedule the patient for the placement of the dental implant. So this is occurring about 2 weeks, 2.5 months after the graft is done, about 2 weeks before they're ready to have their implant placed. So
pretty straightforward, simple case, run-of-the-mill type of case you're seeing on a regular basis, of course.
Very straightforward. The implant was prepped and placed freehand, and as you see, it correlates exactly with what we anticipated and what we planned digitally.
So, no, that was great. Nice, simple case. And then, maybe something a little bit more complex that requires a little more finessing if you will.
Sure. Let's see what I have. Let's see what I have here, Phil.
Oh, let's take a look-see.
Are you seeing my screen?
Yes. Yes.
Are you seeing me at all?
Yes.
You see me and my screen?
I see you and your plush head of hair, and I see your screen.
Oh, it's amazing, this technology that you kids have today. So this patient was referred to me for evaluation of a space for an implant on the lower right-hand side. Patient has been without this tooth for quite some time. So of course, first thing we do is a cone beam CT. We trace the arch in the axial cut, and that for us yields a typical two-dimensional panoramic view. So again, patient's talking to me about an implant in this number 31 position, understanding that you have this mesially inclined number 32, this erupted and relatively functional tooth number 1, and this supra erupted tooth number 2. So that begs the question as to, what to do here. Patient really just wants an implant, hasn't really been advised by her dentist that there's a little more work involved. And although you probably can drop an implant right in here, it's certainly not what the best thing to do looking at it from a comprehensive standpoint. So again, what I do is I bring my vertical line, which gives us a cross section. I try to make it more or less parallel to the long axis of the adjacent tooth and place it more or less where the implant would go. And that should yield for me this image here. So this image is the cross section of this edentulous space where the implant could be placed. In this case, I'm not going to measure. I'm just going to drop in an implant, and you're going to see I could take it to 11 and a half. So maybe in this case, we could put a 10mm implant in without being too concerned. This comes from experience. The textbook will always, always, always tell you stay 2mm north of the superior margin of the inferior alveolar nerve or the mandibular canal. But basically what I'm trying to do here is put in an implant that's the appropriate size. That will emerge either to the central fossa or just palatal to the central fossa of the opposing tooth. And you see, if you place the implant where it belongs, and you're comfortable here, you cannot place a crown with an appropriate mesiodistal relationship. So of course, here you're advising extraction of tooth number 32. If you're taking out 32, you most certainly should also remove tooth number 1, which would be unopposed and clearly would super erupt as 2 has. But here you have a situation where tooth number 2 has super erupted, and therefore, while you can place the implant, you don't really have enough space to put a crown in that would be at the appropriate occlusal height. So this is a case where you need to work closely with the restorative dentist and the patient for them to make a decision as to how they want to handle this case. So sometimes what we'll do is we'll remove the occlusal portion of the crown, treat this tooth endodontically and place a crown on it. Or sometimes if we have a patient who's going to be patient and we have an orthodontist who is, let's just say, capable and willing to do the intrusion of this tooth, then that is actually probably a better way, though a very difficult thing to do in some cases. So first step, in my opinion, is for this patient to see an orthodontist, to have it evaluated to see if they're willing to do that, unless the patient would just prefer to do the
Didn't want to
crown.
spend the time to do it.
Exactly.
For sure, right.
That's exactly right. So for me, that's really where we stand. So this patient has not yet been treated. This is still in an evaluation stage. They are going through the motions and figuring out what they want to do. Understanding, though, that the longer they wait, the more mesially inclined the third is, and the more super erupted the number 2 is. So
is number 2
third
an option to extract number 2?
A third option, of course, would be to extract number 2 and graft it and place an implant. Right, exactly. But if you look at kind of the anatomy of the adjacent roots, the distal buccal root here on tooth number 3 is pretty posterior, and so to try, and the sinuses, in the area. So while not so challenging, a little bit more involved. So if we can kind of keep that tooth, we'd probably be better off. So
ortho is probably the best, minimally invasive route for the patient, right?
Yeah, longer.
But it's just going to take longer. So it's
That's right. That's right.
But
Some things are worth waiting for. You know what I mean, Phil? Thank you, Phil.
Well said. Did you write that? Did you write that
Yes,
yourself?
I think about these things all the time, just different ways of saying things that are clever. All right, Phil, let's talk a little bit about a case like this. A lot of oral surgeons and surgically minded dentists are seeing this type of case. Patient comes in, take a look at the big picture. You see there's generalized, pretty severe bone loss. You see short roots, and like I said, a lot of bone loss. And you have a patient who presents for one specific issue. And that issue is that he came in after having bitten down on something, and tooth number 10 is loose. Tooth number 10 is loose because it already had about 80% bone loss. So this is tooth number 10 in cross section. This is labial. This is the nasal floor. This is the palate going back, lower incisor against it. So this patient bit into something, again, minimal bony support to begin with. Tooth is now loose, highly mobile, and the patient is upset about that. Actually, a very nice patient, but upset about his loose tooth. I took a scan just to understand if I was going to be able to do an immediate implant, and this is the information that I got. I saw that, 80 to 90% of his teeth have severe bone loss and should be addressed. So this is a case actually that would be presented by many surgeons and surgically minded dentists as an all-on case on full arch rehabilitation. And frankly, I'm not one to go in and kind of lead with that, but this is one of those cases where he should have probably done that. And I had a very good rapport with him, and we talked about kind of what needed to be done, and he understood, but he really just wanted to fix this one problem.
Just wanted number 10 fixed, but reality
just
is
one
like
number 10. So again, I have a situation, I don't want to say like an ethical dilemma, but I have a little dilemma to try to figure out what the right thing to do is. I have a patient who understands clearly that all of the teeth are questionable, very, very poor prognosis, and probably should do the full arch. Also has been told by me, clearly understands that to replace each tooth per tooth that comes out with an implant is considerably more costly, long-term more of a problem, and to have periodontally involved teeth around implants is generally not an optimal way of going.
But
But
let me ask you a question here too. Like, I mean, with all that bone loss, obviously, I mean, I would imagine that you're more susceptible for having that mobility on other teeth going forward in the future, right? 100%.
many of his teeth were already mobile,
Yeah,
and many of his teeth will undergo this exact same situation if he continues to treat this way and live this way.
right.
So he knows it, he gets it, but he was again really kind of rational about it and discussed it in like a thoughtful way. And he decided, he's like, listen, I understand, I just want to replace this tooth. So fine, well, let's just replace this tooth. So I take out tooth number 10.
We'll see in a couple months.
Yeah, right. So I take out tooth number 10, and you see what kind of bone we have apical to tooth number 10. And we understand that this is what we're working with. So I actually placed an implant that was more or less like this. So I'll show you what the post-op looks like.
While you're pulling that up, how often are you using the MAR, the metal artifact reduction?
Every time.
Regular, all the time?
Not every time, but often. So this is the immediate post-op periapical film. As you see, the implant was placed, well, you don't know this, but the implant was placed freehand at the same time the tooth was extracted. We got it emerges exactly where it needs to, and it's currently integrating, and we're slated to see this patient pretty soon for his post-op.
I noticed that as you mentioned that it was placed freehand, you're saying that with a little bit of swag, just a little bit.
Yeah, well, if I may, and I say this, and this, you should keep recording while I'm saying this, because this is important, I think, for the young surgeons to understand. Guided, of course. I mean, why not? It's great.
Yeah.
It takes away a significant amount of margin for error, but anybody who does enough implants understands that you get back enough surgical guides despite the quality of the technology, and they don't always fit, or they don't always make it through the procedure. And you have to understand the fundamental basis for what you're doing, and you have to be able to do it without the aid of the technology in case a time comes where there is not that technology. Not that there won't, not that we're going to revert to an older time, but the fact is like, if you got to be able to place an implant. There's an art to what we do, not just a science. It's not just, we're not just technicians. We are surgeons. I mean, it's kind of part of the beauty of it. While I'd love to continue to do this for hours on end, and frankly, if you'd like to come back, we can do this anytime. I think it's time to discuss our final case. So this is a case that's actually a pretty challenging case, because just to kind of show you, going from right to left. So here we're kind of in the area posterior to the lowest portion of the sinus, maybe in the area of tooth number 2. You see that there's okay bone. As you go a little bit more forward, you've got some also okay bone, and now you're here anterior to the sinus, and you're coming around. It's really not very predictable bone. So right here, as you see, right here we're on tooth number 4. We come forward, tooth number 5, tooth number 6, and so on. And we evaluate all the area. Anyone who does hybrid cases understands that you need to have vertical bone reduction in order to facilitate the placement of the prosthesis. Kind of what people talk about is 12 to 15 millimeters of clearance, so that you can have, the substructure and the actual end prosthesis. So patient's got decent quality bone, but not a lot of it. So we plan to do an all-on X case, or a smile in a box, or a
Pro arch.
Pro arch. Yes, we plan.
You're welcome, Ed.
Thank you, Ed. We plan to do a pro arch, obviously, because Straumann. Oh, this is not a Straumann video, but I do use a lot of Straumann, as people know. So basically, what we did was we planned this case for an upper hybrid. We took out the teeth, we planed the bone, leveled the bone, and placed the implants basically all at the same time. We also did bilateral sinus lifting to facilitate some vertical implants in the posterior, because we had better width here, and we had not enough great bone anterior to the sinus to do angled implants. You could have put one a little bit more posterior here. You could think about zygomatic implants, or even pterygoid implants. But this was a very simple, very straightforward case. Patient is very happy. We're able to immediately temporize with an acrylic screw retained hybrid denture on the day of the procedure. These implants were all torqued to 35 newtons, primarily stable, and were able to be loaded immediately. So it's kind of what we look at.
Are you delivering the provisional? I mean, are you bringing the dentist in to do this? I would imagine.
So typically what we do is we bring the restoring dentist or prosthodontist, the lab tech, with whom we work very closely, me, and if the case warrants it, sometimes I'll bring an anesthesiologist in. We do our own anesthesia for the most part, but if the case warrants it, then we will bring an anesthesiologist in. So coordinating the schedules is of the utmost importance, and conversion of the denture chair side at the time is how we do it. I will tell you that there are kind of newer, enhanced ways of doing this type of stuff, as you know, as I'm sure most of your viewers know. But I'm kind of a tried and true type of guy.
Tried and true. I was going to say exactly. Okay.
Thank you, Phil.
Fair enough. Yeah. You're welcome. You're welcome.
Thank you.
No, this is good. This is good. This is perfect. Honestly, this is great to kind of go through it, just to kind of understand. I think this will help a lot of viewers. Definitely check out Bloody Tooth Guy on Instagram for sure. Right?
Well, if they want, there's no obligation. Please don't feel obligated.
You mean they don't have to? Okay. So you don't have to. You don't have to. Only if you want.
Only if you want.
yeah, anything else you need to plug? I appreciate you doing this again. This was great.
No, I mean, there's no plugging. I'm doing this out of love. I'm doing this out of appreciation for your support. Anyone who understands anything about dealing with uh, dental companies, surgical companies, understands that the relationship with the representative of that company is paramount to a successful outcome or implementation of the technology that you're using, or whatever it is you're buying from them. So, Phil, you have been a truly. This is I'm not just saying this for your benefit. I'm saying it for anyone who's even considering working with you, Phil. You have been a tremendous friend to the practice and helpful in every way. And I think you differentiate yourself because you actually care about the end user. There are a lot of people out there, reps, who sell the product or sell the service, and then it's kind of like once the sale is over, so too is that relationship. You continuously raise the bar in terms of how the relationship between the representative of the company and the end user should be. And I will tell you, without a doubt, Carestream is lucky to have you. Let's just say that.
You're making me cry.
No, I appreciate it. It means a lot. It means a lot. I know you're being honest and sincere. We're joking around a bit. So yeah, I appreciate it, man.
Yeah, no, I mean, I hope that's definitely out. Anyone who doesn't know, I'm from New York. I live in New Jersey. Sarcasm for me is part of how I speak, but I'm not being in any way disingenuous. This is how I really feel about Phil, and that's it.
So listen, go to your dinner. I appreciate it again doing this. We'll talk to you soon. Hopefully this was helpful for everybody. Okay, thanks again.
My pleasure. Thank you. You should keep all that in the video. I'm just telling you. Do not cut that out. That was gold. That was.
If anybody's still actually watching at the end.
Yeah. Right, exactly. By the way, you should keep this in because this too is gold.
Thanks, man. All right, I appreciate it.